Okay, hi Corderis, Dr. Buford. We're just getting started on the right knee. We're having a good look inside the medial compartment here. This is one of the areas that we were concerned about based on your symptoms and on the MRI scan. And we'll actually start anterior. So this is the anterior part of the meniscus, anterior horn we call it. It looks fine. As we rotate back around, we'll see the body of the meniscus. And that's what we're seeing here. This is the body. You can see the meniscocapsular junction here. We can look underneath. And that meniscus looks intact. How do I turn the brightness up a little bit? Okay. And then we'll rotate around and look at the posterior horn, which is back here. And then here's the kind of the root of the meniscus, way in the back here. Hold the camera for a minute, please. And that looks pretty good. Now what I'm concerned about, and what the MRI suggested, is that this area right here might be unstable, but it actually looks pretty good. Like we talked about in the office, there's no way to tell that until we look at it, but you can see this kind of, this is the outline of it right here. It's not loose, so this actually may be really good news and a relatively shorter surgery if we don't have to transfer any cartilage. Flex the knee. You can kind of see the bend the knee. There's certainly nothing deeper under here, and then slowly extend. That's the area that we're concerned about. You can almost see where it's tried to heal, which is excellent news right here, because that's basically the area that we were concerned about on the MRI scan. Okay, so we'll look over here at the ACL, the anterior cruciate ligament. The posterior cruciate ligament's behind this bit of fat right here on the right. The ACL is this ligament here, runs up to the back of the knee, and your knee was stable under exam, under anesthesia. And we can see why. It's because your ACL looks pretty good. Okay. Okay, so this is the lateral compartment. Here's the posterior horn of the lateral meniscus. That looks good. Table down a little bit, please. And then this is more the body of the meniscus. Let's do this. Pause for a second. Okay, and so here's the problem on the lateral side. Look what happens to this meniscus. Back here it's great, but as we follow the inner edge, this is a tear right back through here. So that's a tough one to repair because it really doesn't extend back to the part of the meniscus that gets a good blood supply. You can see that there's really no blood supply in that part of the meniscus right there. We are just trying to assess how much of the meniscus we would have to resect. Looks like we would have to come across right about here. And that would still leave a stable rim. Okay, we're going to decide what to do and show you some more in a minute. Okay, so here's where we're at right now. We've taken away a little bit of the meniscus. You can see still a little bit rough on the edges, but that's microscopic because things are magnified so much, like we said, 30 or 40 times. There's a popliteus tendon back there, probe. Yeah. And there's popliteus. And so we've resected in this area here. You can still see there's a little bit of a split there. I think that'll be okay. And I think I'm going to convince you to let me do at least some PRP or maybe even a BMC injection in the office. But right now, I don't think I want to take any more significant amounts of meniscus away. Okay, so now we're looking up at the patella, the top of the screen. That looks good. This is the lateral facet way over here. As we push in, there's the medial facet. A little bit of a air bubble there, not to worry. And then we'll look down here at the trochlea, which is the groove that the patella glides on. As you flex and extend your knee, we can see all the way down to the front of the knee here. And that cartilage looks pretty good also. So it looks like the main story here is going to be that lateral meniscus. Let me go back to that. Flex the knee again for me. Okay, and so here's what we've done. We've trimmed it back to stable margin here and gotten rid of that flap tear, which are difficult tears to repair. Now, if we had... No, I wouldn't change a thing. I think that looks pretty good. So we're going to keep looking. If there's anything else that we do surgically, we'll come back up on the video. Otherwise, I think we'll be finished here, okay? So good luck to you now. It's a bit less surgery than the cartilage transfer, so hopefully you'll recover that much faster.